Hi, my name is Adesuwa I Akhetuamhen,
My name is Abiye Ibiebele.
and we are fourth-year residents at Northwestern's Emergency Medicine program. We are very excited to talk to you today about how we were able to, with the help of our mentor, M Bailitz, create an emergency medicine resident cultural competency curriculum. We have no disclosures. Cultural competency is defined as the ability to effectively use cultural knowledge and skills in cross-cultural encounters. It truly is a learned skill that helps us to understand our patients' backgrounds so that we can better understand where they're coming from and address their needs. Now, there's a lot of controversy around cultural competency. So as educators in this topic, it's really important that you understand two major things. First, no physician can ever be an expert in someone's culture. In fact, the authors of cultural competency understand this because in their definition, they include that cultural competency is an ongoing, lifelong developmental process that requires consistent growth. The second thing to emphasize when you're teaching this topic is that cultural competency is not the end-all, be-all solution to address health disparities, but in fact, it's just the start. Once we physicians understand our biases and the stereotypes that we have towards our patients and how that can impact their care, we can then take the next steps to educate ourselves about all aspects that can affect a patient's care, such as social determinants of health and other elements of structural competency. So now let's get into the actual curriculum development. Kern's model is a well-established model for developing curriculum in medical education. It's 6 steps that's listed here. And throughout our talk, we're gonna explain how we were able to integrate each element into developing our curriculum. So the general needs assessment was done in 2017 by a group out in Israel. They submitted a survey to program directors, and of those who responded, 68.5% of them said that they actually have a cultural competency course, which shows that there's obviously room for improvement. In addition, 93% of them said that they wanted a universal curriculum, which makes sense because you want to make sure that you integrate all elements of cultural competency into your training. However, we feel that it's important to understand that cultural competency in one institution will be taught differently than in another institution because you really have to tailor what you're teaching to the needs of your patient population. In addition, there are some programs that already have elements of cultural competency in their core curriculum. And so we wanted to find a way for programs to find how they could develop curriculum that would meet their institutional needs. And using Kern's model, we've been able to do so. The next thing we did was to find a targeted needs assessment. Now, there's a lot of surveys out there, but the ones that we decided to use was the tool for assessing cultural competency training, or the TACT survey. Now, this was developed by the Association of American Medical Colleges for use in medical schools, and they brought a group together of experts who decided to figure out what aspects encompassed cultural competency. They found 42 educational objectives, and they broke them down into the 6 domains listed there. Now, not only has the TACT been used in medical schools, but it's been adapted in multiple other areas, such as nursing education, dental education, and even rehabilitation programs. And so we thought, why can't we adapt it for use in emergency medicine? And we did. We were able to make very minor modifications to the TACT survey so that we could utilize it to better address the needs of emergency medicine residents and faculty.
So talking about the TAC survey, what we did was we took the bottom quartile objectives and we used it to develop our curriculum. And so what we did was we took the bottom quartile and they're listed there, the objectives that ended up being the bottom quartile for our participants. So based on that, what we did was we partnered with our residency and our department leadership and staff to identify content experts. And we also used this textbook, Diversity, Inclusion, and Quality Patient Care. And what we did was we used this textbook to draw from case-based studies and draw some core concepts to pass on in our curriculum. So based off of that, we decided to implement our curriculum. So we partnered with our residency leadership and we created a 2-year curriculum that was developed with 8 modules over the 2 years, with 4 modules a year. So they're listed there. Sessions included race and implicit bias and homelessness, as well as human trafficking and social determinants of health. So finally, what we did was, for evaluation and feedback, we developed 2 surveys. The first survey being a post-course survey that was more of a qualitative assessment, which we asked people what they thought of the curriculum. We asked them about their practices before and after the curriculum, and they're listed as some of the quotes from this survey. The other thing we're doing is we are administering the tax survey as a post-course survey to determine what needs our curriculum still needs to meet and how we can further expand our curriculum. So we are currently in the process of that sort of process, and we will hopefully have some data to share at the end of all of this. But in conclusion, we wanted to show that we use Kern's model to develop an emergency medicine cultural competency curriculum, and that we were able to develop a specific curriculum for our institution. We hope that other institutions can use a similar method to develop their own cultural competency curriculums. So we would just like to thank you for the chance to present today, and our emails are listed if you have any questions.
Thank you.